So very good morning to all of you, and welcome to this IC on ICL, perfecting ICL outcomes. And joining with me are the leading ICL surgeons in the country. I'll invite Dr. Kamal Bandhu Kapoor, who will be talking on patient selection and sizing. Kamal is a prolific, high-volume phakic IL surgeon, and they are leading from the front and starting their chain of eye hospitals across India. Joining with me would be Dr. Krishna Prasad Kudlu, who will be talking on VALT, the success marker. Again, Dr. KP is a high-volume ICL surgeon and a great phaco-refractive surgeon as well. Then would be Dr. Gaurav Luthra, nightmares with ICL surgery, my 2 cents. And Gaurav, again, is a high-volume ICL surgeon and a great phaco-refractive surgeon practicing in Drishti at Dehradun. And the last speaker would be Dr. Sanjay Chaudhary, where he would be talking of the long-term outcomes with ICL surgery. And Sanjay has been doing ICL since the inception of the day these came to the country. So he'll be talking of long-term results and his outcomes and his personal experience. So welcome you all, early morning. And to begin with, we have Kamal. And Kamal would be talking on the patient selection and sizing. So before beginning the course, I would just like you to raise your hands. How many people are practicing ICL in their daily practice? Very nice. So the course basically intends to answer the queries to people who have been practicing ICL, and for people who want to begin, we'll be addressing how to start and how to make ICL a very regular practice in their refractive surgery. So it's not necessary whether you have all those fancy gadgets and expensive equipments in your practice, because in China, now it's called refractive clinics or ICL clinics, where every cataract surgeon is practicing refractive surgery. And believe me, ICL is much easier than even a cataract or a phaco surgery. So let's hear from Dr. Kamal. All to you, Kamal.
A very good morning to all of you here. It's a pleasant surprise to see people early morning, 9 o'clock session. And that definitely shows that the interest in phakic IOLs is up and rising. I could not agree more with my friend Sonu here. Phakic IOLs are, it's a cliche statement that they're here to stay. In my practice, across all my centers, we made a plan not to buy any more LASIK machines. It might sound harsh. We already have 4, but we don't plan buy any more LASIK machines. We plan to take care of any refractive error with phakic IOLs, oblique clear lens extractions, and other options available. Sounds jarring. It's a disruptive idea, but just wait another few years and you will see this idea working. So I'll be talking about phakic IOLs in general, how to get it right. Because the main game of the procedure is not the surgery itself, but the measurements and sizing. So we have to be knowing our sizing and patient evaluation very, very accurately. My main interest is mainly IPCL. I do a lot of ICLs also, but I think I probably have the largest series in the world in IPCL, nearly 3,000 done, or probably more. So the options available majorly in the market are 2 competitors, the ICL and the IPCL. What would be the exclusion criteria for the patients? Whenever you see a sclerotic cataract, you may miss it. Always dilate the patient and do a distant direct ophthalmoscopy. Early sclerotic cataracts you may miss on slit lamp. Any small evidence of nuclear sclerosis, do not think of phakic IOL or a clear lens extraction. Do a cataract surgery. Corneal dystrophies, low endothelial counts, anterior chamber depth less than 2.8. Again, there's a little small caveat here. Surgeons who are at advanced stage can play around with lesser also. There was some interesting discussion yesterday in another hall where I was doing a session. But I would say the cutoff mark would be 2.8. Any history of uveitis, posterior shiny K, old history of uveal inflammation, think twice. If you have a lens rise more than 600 microns, we will see what lens rise is. Shallow angles, mid-dilating or mildly dilating pupils are a little bit of a semi-contraindication, especially for a beginner surgeon. If your pupil is not dilating well, you can have problems putting in phakic lenses. Very large pupils also are contraindications, semi-contraindications, because you would need larger optic sizes and they're a little tricky to manage. Iris cyst, I've had 3 or 4 cases where I did an UBM only later on to find out that there was an iris cyst here. History of retinal detachment, and of course keratoconus. Keratoconus can be very tricky. Keratoconus can actually give you a very false anterior chamber depth. So you have to watch out for the angles. You have to watch out for a complete gonioscopy, watch the angles, plan a lower vault in keratoconus. Do not get excited and plan a higher vault. In keratoconus, plan a little bit larger optic size because the cornea cone could be a little eccentric. So when you go for a larger optic size, you cannot have a normal vault. Go for a slight smaller vault. So nearly these are cases of combination in IPCL and ICLs. These are the options available in sizes and powers, both in ICLs and IPCL. Of course, as you see, the ICL is a little available in higher powers, though I think I probably have another world record of correcting -38 with 4 diopter cylinder with an IPCL. Also corrected up to -14 diopters of astigmatism. So these are the sizes actually available in both. So if you see on your left, you have size combinations of 4 sizes, and on your right, you have sizes of 13 combinations. So they both have their plus and minus points. I guess when you plan to have a vault which is more forgiving, then you go in for 0.25 millimeter, because there are some issues when you actually plan a smaller vault, but you don't have a large size available. So then you only have an option of 0.5 increment. So there you can fine tune. Especially when you're planning toric lenses. In toric lenses, you have to plan a little higher vault because you want the lens to be tighter. You don't want it to rotate. But in a non-toric or a simple sphere lens, you can get away with a lower vault because even if the lens rotates 10, 15, 20 degrees, you don't have a problem. So another trick is when you're planning a toric lens, plan a little higher vault. So for example, every 0.25 millimeter increase in the diameter, the diagonal diameter of the lens, increases the vault by approximately 180 to 200 microns. So you can actually size the way you want. So what are the assessments for the phakic lens? Of course, refraction. Please do a dilated cycloplegic refraction, because you'll be surprised the patient walks in wearing -9, but he's using accommodation. I've had patients who are wearing -8, -9, but their cycloplegic refraction said 5.5 or 6 or 6.5. And they've been used to that. So you need to do a fogging test, you need to do a cycloplegic evaluation, because even these myopes could be accommodating because of a wrong spectacle power given to them over some time. Whenever you have more than 2 diopters of white to white astigmatism difference between both the eyes, I prefer doing a vertical diameter also. Preoperative scotopic size of pupil is very important, because then you need to plan in on going for a lens with a larger optic size. When the cornea is large, especially more than 12 millimeter white to white, please confirm the maximum dilatation. If your dilatation is not more than 8 millimeter, this could be slightly tricky for a beginner surgeon. Keratoconus, as I said, be careful. The lens rise has to be measured. Intraocular pressure, disc evaluation, specular microscopy. So these are the various situations I've encountered: healed corneal scars, repaired corneal perforations, keratoconus, piggyback lenses. So these phakic lenses can be used wherever you want. I've used them as secondary IOLs in patients I operated 20 years ago, congenital cataracts or developmental cataracts, and these patients have got big fibrous bags and they have high myopia, -17 with 3 diopter cylinder, anterior chamber is little small. I go in with a phakic IOL and they do very well. So the break points could be always a bad refraction or a wrong acceptance. White to white is the most important concept here. So as Dr. Sonu said, we don't need fancy machines to do that. I will teach you how to do that in the normal setup. In case you have any confusion, throw the data to the manufacturer or the ICL or the IPCL manufacturer, they'll help you. Partially dilating pupils, watch out. Avoid using pilocarpine in patients, especially if you're a beginner surgeon, because this will help you This will have more of viscoelastic retained behind the IPCL or the ICL. You will have a flatter vault for first 3-4 days. So you will have problems. So if you put a pilocarpine or a myotic in this patient postoperatively, you will get a lower vault than required. I have seen less than 350 microns of vault going down on using pilocarpine. And then at times you get scared what is happening. So do not always avoid using a myotic. If you see minimal opacities behind the phakic lens within the first 2-3 days, relax. This is not cataract. This is viscoelastic. Just do an AIOC and you will see something white there. Watch out for IOP peaks within first few hours or first few days, and then after 7 days, because you could have steroid responders. So let's go to the sizing. Most important, as I said, is refraction. Measuring of the pupil size is very important, which probably most of the courses are not talking about. This will actually help you to plan your surgery, size your optic size, and also decide what is the kind of viscoelastic you may be using. Pupil size, of course, is, as we all know, the amount of pupil size you see on your measurement is approximately 25% less. So this could be a vague chart you can go by. How do we measure our pupil size? We do a dynamic pupillometry. You could have a Cirrus machine or any other machine which does pupillometry for you. Or you could also use your standard ARK machine to do pupil size measurement. Anterior chamber depth measurement can be done by Cirrus, your Pentacam, your OBSCAN, or even a simple immersion biometry. Just do your immersion biometry or do a central pachymetry on your AIOC, subtract. I've done a series of thousands of patients. It is just varying between 0.1 to max 0.15 millimeter. Beyond ACD, always check for angle anomalies. Their angles are closed. There are some cysts there. There is some pigmentation there. So watch out for these. If the crystalline lens rise is higher, be careful. If your lens rise is more than 600 microns, plan a higher vault. And if you are planning a higher vault, but you don't have a good ACD, then plan a smaller optic. Because these situations, in spite of whatever you do, even a resting size of a good vault will not stay so, because as time goes by, the lens rise will increase in these patients. So what if your anterior chamber depth is 2.8 or more? Are you totally safe? Well, yes or no. You could have angle anomalies. Your resting pupil size has to be very, very important. If you have a small or a non-dilating pupil, again, watch out. So this is in case, even if you're 2.8 and above, these are the things you watch out for. Look for iris cysts. Look for lens rise. Keratoconus, posterior synechiae, heel uveitis. So these are the things you walk out. So how do you measure white to white? Most of the people say this is a good method. In my personal opinion, this is only a check method. This should not be a baseline. Use 2-3 methods. Only use this to confirm. I have given this test to 3 of my best senior optometrists. Each one of them comes with a different reading. And when I do it, I get a different reading. So this is a good marker for you to know what is the average you're looking at. Always look at the mid-limbal line. You could use a caliper for that, or you could also use an ARK. In fact, in my setup, we found this method far more repeatable between ARKs to do a white-to-white at the mid-limbal. The only requisite is you should have a screen which has got a good resolution. There are some machines out there in the market, probably out there in the stalls also, which we use for this. Planning a vault ideally should be anything between 400 to 750, but then with the present lenses which have central holes, and the IPCL also has peripheral holes, I have even patients who've got vaults up to 1200, 1300, and they're doing fine. So in an ICL, the vault size, usually you can play between 1.5 millimeter. What kind of lens to plan is, again, depends what is the kind of spherical power you correcting. You can land up in some issues because the powers available are in 0.5. This problem is taken care when you move into an ICL. In an ICL, if I have a toric lens, I go one size larger, the next size. Suppose I need 12.75 for a spherical lens, I will go for a 13 if I'm using a toric lens. Because this 13 will just give me maybe 150 to 180, 200 microns higher vault, but it will make my lens far more stable. This is what lens rise is. You do an AIOC and draw a straight line from one angle to another angle. The area which rises above this straight line to the crystalline lens central part height is your lens rise. Most of the machines, if you activate in the software, will give you lens rise. Like we use Cirrus in all our centers, so I've activated that button. I get a complete detail of the lens rise and the angle in one shot, and I can actually decide what is the kind of lens vault I'm planning. So please look out for lens rise. Most of the people are not talking about that. Wide to wide trick is if both the eyes have high astigmatism, different astigmatism, then you're okay with more than 0.2 millimeter difference between both the eyes. But if both the eyes have different wide to wide bit of more than 0.2, recheck again. There could be some pigmentation, there could be some scar on the cornea if you're using an automated method. So please watch out. Anything more than 0.2 is tricky. Planning a larger vault could be, again, this is an important slide. So more than 0.2 millimeter reading, watch out the difference. Normally plan 1.25, larger size than what you have. You can plan a small size also, a 0.75 if you're using a large optic diameter. You can also use 1 millimeter size difference, again, depending on the kind of the crystalline lens rise you have. Vertical measurement, if the astigmatism is more than 2 diopters, measure the vertical diameter also. And high astigmatism, high AC depth, please be careful. A keratoconus patient can be very, very scary because you can have all the wrong data and you can have an angle block. I've had so many patients that. And 0.25 millimeter size change will increase the vault to 150 to 180. Thank you.
Thank you, Kamal, for that wonderful presentation. So let's pick up two questions. Yes, please.
Fantastic. Okay. When you have an astigmatism, especially if your vertical axis is steeper, remember the lens is not a straight line. It has a width. 6.2, especially if you have a large optic size, 7.2. And most of these cases, high astigmatism, we already plan a large size because I want more area to be covered. So if you have a straight line lens, then just knowing the horizontal is good enough. But if your lens is 6 millimeter larger, I also need to know what's happening here because you could land up with a very high vault if you have a very high astigmatism because the cornea is compressed here. So the lens on the edges is compressed. So you will have an asymmetric vault. You do an ASOCT in these patients dilated. The lens in a horizontal section rises like a tent. So that's how you should know. So that will help you plan your optic size. Yes, of course. See, there are studies which say that the STS and WTW can be corroborative, and sometimes I've done hundreds of cases, and sometimes they totally go haywire. Probably 7 to 8% of your cases where your vault is not going according to plan is, guess what? Your STS is not matching to WTW. So here again, if you know your vertical vault, you can actually plan the size far more perfectly. You see, my target is 84%. 84% of phakic IOLs in my organization are landing within 80 to 100 microns of plan because of such a meticulous workup. So it will always help you because the vertical size, if it's smaller, will add to the vault. Anything more than 2 diopters, please measure the vertical dia. Yes. The lens rise is only measured in the center. No, I am using Optopol, so I get a complete 12 millimeter cut section. So 12 millimeter will give you approximate idea to draw a straight line, and then the lens rise is great. Yeah. So I hope you understood. The lens rise is important because if you have a high lens rise, do not plan a normal vault. Plan a vault probably 0.25 millimeter higher. Yeah, that's exactly what I'm saying. You know, that's an issue I have with ICL, nothing personal against it, because the range is quite erratic. You just 0.1, you jump and you're 1.5 millimeter higher. Depending on the ACD. If your ACD, okay, again, my cutoff is, if my ACD is more than 3.1, I can play football in the eye. But if it's less than 3, that's where you become a little careful. A higher ACD for more than 3.2 in keratoconus is not a free field for you to play. A higher ACD of more than 3.2 in a large resting pupil size is not your field to play. A higher ACD in a patient who's got 6 diopters of astigmatism, vertical axis steeper, is not your field to play. So these are small points which you all beginners should know, that the clear-cut ACD of 2.8 and above is not your playing field. You have to look out for other things also. I would like to go in for a higher vault, because lower vault, as we all know, as the patient ages, the lens rise goes up. 20 microns every 2-3 years.
So, Kamal,
So I plan a higher vault.
I think this answers her query. Now, do you see this chart? Do you see this chart? So the moment your white to white jumps from 11.14 to 1.5, there's a change in the size.
So this is what happens.
So you get my point. So the moment your measurement is as small as 0.1, so that is the bridge, and that is where they would ask you to recalculate, reconfirm, So there is a change in the size just for a 0.1 millimeter. And just for the ACD, just take a check of the ACD as well. From 3, so you can have 2 variables. So if I have an ACD of 3, I can either have a 12.6 or a 12.1, but my white to white is what determines the size now. So for both the ACDs, I can have 12.1 and 12.6. Now it is after your experience, then you would then trust whether you want a vault, maybe a lower vault, maybe close to 350 or 400, or you're aiming for a higher vault. Now that is you to decide. Now the dictum has shifted to have a slightly on the higher side rather than going on to the lower side, if you have wide angles. So I think that, thank you. Please, I interrupted. So any more questions for Kamal? We have now, since we are running a parallel national symposium on refractive, and we have the subspecialty on refractive, so we are all having common talks. So I have now Dr. K.P. Kudlu, a prolific surgeon, and he's one of the leading ICL surgeons in India, and he'll be sharing on his experience what is vault actually, and what is vault determining the refractive outcomes, and long-term, what are you looking for the vault? So all to you, KP.
Thank you, Dr. Sonu, for including me in this wonderful program, and also very important instruction course. I think a lot of people are started doing these phakic surgeries. I think most of my points, I think Dr. Kamal might have been already spoken. I don't have much job to do that. So as he already said, that posterior chamber intraocular lens implantation is a technique to correct a very high myopia. However, the number of ICL has been, even now people are started implanting in the low and moderate myopia too. With the increased surgical number, the possible complication also can go up. But one important thing, the central hole in the phakic IOL was a significant improvement in the design. Always I started my phakic IOL practice almost 15 years back. That time we did not have a central hole. The chances of increasing in the intraocular pressure also, cataract formation was much higher, but probably the greatest innovation goes to this central hole. But complications do happen with any of the surgery. But the most common one in this phakic lens is none other than the vault. So what exactly is the vault? It is the space between the posterior surface of the phakic lens and the anterior surface of the human crystalline lens. So what should be the phakic, ideal size phakic IOL which provide a vault within a range of 250 to 750 micron? That means, in other sense, to tell that half a corneal thickness to 1.5 corneal thickness. So when we call it is as an undersized lens, when the vault is less than 125 micron, so in such cases, definitely there is an increased risk of patient may develop anterior subcapsular opacification. So when we call it is a oversized lens, when the vault is more than 1000 micron. So what will happen if you have got a high vault, it may push the iris forward and chances of becoming close angles and chances of increasing the intraocular pressure and also iris malfunction. There are different methods to measure the vault. Normally it is measured by anti-segment OCT, and you can even measure by the slit lamp manually also. So always, as Kamal said, that it is directly correlated to the size of the phakic IOL. Undersized phakic IOL that causes low vault, you have to remember. Oversized IOL causes high vault. So once again, I think already been explained in very, very important is white to white, its relationship with the vault. So you can see here, there is a normal vault post-operatively. So you can see here, patient with a normal vault with a very high vault, which can causing a pupillary block and an increased risk of angle closure glaucoma. See here you can see a vault of around 793 micron. So here you can see the anter-segment showing the low vault postoperatively, causing a risk of subcapsular opacification. So it is almost touching the antercapsule. So this is a few of the slit lamp images to show how exactly oversized high vault can be seen. This is about the slit lamp examination of low vault. How can you see in the slit lamp? Because why I am showing you how you will see in the slit lamp about vault measurement, how you have to see in the anter-segment OCT. This is very important because once a patient comes to you, all see in the slit lamp, your mind has to go whether it is high vault or normal vault. So this is the schematic image of external white to white and the internal measurement angle to angle, sulcus to sulcus distance, and the lens size relevant for sizing of phakic IOL. This is very, very, very important. So there are different tools available in the market. Once again, I am touching here about to measure the white to white. I think the older version of Orb scan used to give a fantastic results. Pentacam gives, IOL Master 700, Lenstar, Sirius, OPD scan by Nidec also, optical biometry, but most of us, I think, depend upon this digital calipers. See, this is how Orb scan gives. Normally, those who are well versed to the Orb scan, they can first do the Orb scan, write down the reading. If you are having IOL Master 500 or 700 also, it gives the white to white. OPD scan also give quite accurate white to white. See, but very important to show how you do with the digital calipers. You have to do the calibration for digital caliper. This is very, very important. A lot of people, they do monthly once case, they kept it in the box. Then when they take out these digital calipers, it may give a very wrong reading. So you have to calibrate these digital calipers. So best to do a white to white only. We used to tell, I have done last few cases with black to black. Some of my ICLs are becoming a undersized. So now once again I gone back to the white to white measurement. So these are the pearls for white to white. So white to white measurement by digital calipers, after you do, I think I take this digital calipers, put it in front of the scale, double check with the measurement. So digital calipers should be done under the microscope in a high resolution, measured from mid-limbus to the mid-limbus. This is very, very important. You can use OBSCAN also to validate the caliper measurement, very, very important. If you have got a IOL master or similar device, make sure that it validates the output. Some reports of IOL masters say that 500, it gives a overestimation of white to white. Especially you should be very careful, patients with pterygium, pigmented area around the cornea. Evaluate discrepancies between measuring devices and between the eyes. Both eyes should have about same white to white. This is very, very important. Let me come to the 1 or 2 points about the ultrasound biomicroscopy with a high frequency ultrasound that provides the exact information through slit lamp microscopy and segment OCT. So preoperatively, we used to use it for post-iris to see the post-iris anomalies. Probably this is the only one instrument which can give the actual sulcus to sulcus measurement, which could exactly ascertain the size of the phakic IOL. But to do this ultrasound biomicroscopy, you need experience. You need to do a repeated time, then only to make yourself best for that. Post-operatively, it evaluate the appropriate position of the phakic IOL of the posterior chamber, including optical zone, bilateral haptic, relation to the iris, crystalline lens, zonules, and ciliary body. This is what we see in ultrasound biomicroscopy. So, measurement of high vault, vaulting beyond management of high vault, vaulting beyond 750 micron. As I already said that there is a possibilities of glaucoma and narrowing of the angle. Suppose if you put a plane or spherical ICL, you can rotate the ICL from horizontal to the vertical position. This will lower the vault by around 200 microns. Why it is? Because always you know that vertical white to white is higher than the horizontal white to white. Then in such cases, you can repeat the gonioscopy every visit to note the development of antrasynechia. Toric phakic lens with a very high vault, more than 1000 micron, better to plan for a phakic IOL exchange. So how you manage the lower vault? If the vault lower than 250 micron, keep a watch, because I had already told because of the central hole. In toric phakic IOL, sometimes if it is a low vault, if you already implant a toric phakic IOL, the chances of rotation will be very high. As I said already before, cataract is the most common complication. So every time you have to do a dilated fundus examination, note for peripheral development of the lenticular opacity. If present, plan for explant and exchange the right sized ICL. Case reported vault as low as 120 micron can also left alone in presence of with a central hole. So in conclusion, phakic intraocular lens, especially the ICL session, which has changed the course of the refractive surgery. With the new designs and newer companies for phakic IOL, due diligence is required for vault measurement too. Vault measurement is important as can make or break the success of the surgery. Use of newer technology for diagnosing, measuring, planning of surgery helps in prevent major complication later. Very important, calibration, validation of measuring white to white equipment is of absolute importance. Once again, I thank Sonu for including me this wonderful IC. Thank you one and all.
Thank you, Dr. Kudlu. Very lucid, starting from basics to advanced. I think now the course master himself, Dr. Sonu, he is going to talk about intraoperative tricks while implanting the phakic IOL.
So I'll take a minute. Meanwhile, we can have a small discussion. So any point that you want to ask about the vault, any clarification? A lot of people keep on asking, if you have a low vault, when to exchange? So Kamal and KP, I would just like to your view. So if you have a vault, what are your criteria? Low vault, maybe 150 microns. The lens is stable, the refraction is stable, and so how do you go about it? I mean, a lot of people keep on asking, sir, I have a low vault. Should I remove the lens, put in a next lens, or should I observe? And this, I'm talking about the latest, the EVO, the V4C, where you have a central hole. And so what is your experience in that?
Okay. My golden criteria is if the vault is less than 250, keeping the patient under close watch, but I'm ready to explant the lens at any time. Because see, you cannot have these patients forever coming under your watch. That's first. Number two, telling the patient that, I need to keep following you up because there is some issue, puts a lot of stress in the patient's mind. And we must understand, explanting and changing the lens is very simple. Once you mastered the implantation of the lens, it's very simple. It takes 1 or 2 cases for you to know how to explant it. In fact, I feel that's the biggest advantage with the phakic lens, which is not there with refractive corneal surgery. It's not reversible. So this is a reversible procedure. So in my hands, Sonu, if I have a lower vault, less than 250, if I have less vault than 250, and especially this patient is not keen on follow-up or cannot be on follow-up, the lens comes out and is changed.
Yeah, in my case series, patients are coming for follow-up of around, voltage around 200 also for 7 to 8 years. Till today not happened. But as he already said that these patients, they'll come for follow-up for first 3 months, then suddenly they stop, then they come back after 5 years with the cataract formation. We have to remember that. Why we ophthalmologists little bit hesitating to do eye selection, sometimes they are little bit scared of company may charge them one more lens rate also. That is the one reason I think people tend to delay or call the patient afterwards. I think I go with Kamal, as he said that I think if it is too low vault, I think less than 200, I think we have to immediately do the lens
Correct.
exchange.
So this is a small flow chart that I've made for the convenience of all. So normally, as Dr. KP here rightly pointed out, you have a patient high vault, the pressures are normal, you can just observe the patient. But if the patient has a high IOP, the chambers are shallow, you can easily rotate, flip the lens vertically if it's a non-toric lens. Because we all know that the vertical white to white is more than the horizontal white to white. So if you have IOP is high, the chambers are shallow, just flip the lens, go in, put in viscoelastic, or maybe just use the hydro if you have that experience, and just gently rotate the lens vertically. You'll have, as he rightly said, the vault goes down. Now, if you have a toric, but you have a high IOP and the chambers are shallow, you need to exchange this for one size lower. With the V4C, the experience that we have and the experience of all the faculties and the key opinion leaders across has been that if you have a low vault, especially with the V4C, but there is no peripheral touch, you can still observe. But as very rightly pointed out by the two co-instructors, that the patient has to be on a regular follow-up. Now, if the patient is reluctant or the patient you see or you feel will not be on a follow-up, it's better to exchange, to err on that side. Otherwise, if you can maintain a follow-up, you can just observe. Now, under dilated examination, you see there is a peripheral touch. There is no cataract. Still, you can observe if it's a V4C. The patient has to be under observation. Now, if you see there is an early non-progressive opacities, now that's quite debatable, but these are non-progressive. That means one sitting you see after 3 months, after 6 months, and you see that the opacities you've marked are not increasing. You can still observe. But if you see the opacities or the cataract is progressive, these are increasing, now that's a very, very important indication for an explant or exchange one size up. So I say explant also. If it's a cataract which is progressive, you can just observe by putting one size up. And if you feel the opacity has stopped progressing, then you can still continue. Otherwise, the lens comes out, and maybe if the cataract is still progressive, then needs a cataract surgery. So what is important is keeping the patient under observation. So this is a small flow diagram which could, help you deciding. So thank you, KP, for making us understand. So I'll be just taking you through a small video which shows how intraoperatively we can So I think the major part of the surgical procedure has been explained. So this is a small video which I developed, and this just basically takes care of how, in our routine practice, this is just for the beginners if they want to begin, but most of this part has been covered. So quick, this is how the patient comes to us, slit lamp examination. There are certain criteria which already have been spoken by Kamal beautifully, explained beautifully, who is the right candidate for the ICL surgery. And so these are the various equipments that check through. And these are just, believe me, the normal equipments that you all have in your routine practice, the AR, the NCTs, the topographers, nothing fancy about it. So calculation has already been spoken, the right sizing of the patient when you are taking these patients. And we do a topography to ascertain the axis and the magnitude of astigmatism. Pentacam is the only tool for me, the most accurate tool in my practice for the anterior chamber depth. We routinely do a specular because specular is again one big criteria for the selection. These are the criteria for the endothelial cell densities depending upon the age and the anterior chamber depth, which we follow routinely in our practice. And we use both ILMaster 500 and Pentacam, but ultimately we, as Kamal pointed out, it's the white to white depending upon correlation between both the digital and all the equipments. So intraoperatively is what I'll be talking on. So ICL, believe me, is a very delicate stuff. So it's a no-touch technique. The optic should never be touched because the moment you grasp the optic with either a McPherson or any of the instrument, it causes those striae, the lines, scratches. So don't do that. Always hold it if you really want to hold from the haptic portion. You can pull the cartridge, I'll be showing in the video. Avoid any undue force while pulling because if you pull, it might rip off the haptic or break or fracture the optic. So very gently, you have this beautiful sponge. You need to hydrate this. And most of the times, you can just pull this ICL. At times, because of the gumming, it can stick to the bottleneck. You can just hydrate the bottleneck and just mark my action. I'm tapping and I'm just simply pronating so that the optic and the haptic edge goes down and I'm trying to make it, just watch, convex. Now tap, any air underneath the visco goes off. This is the forceps, grasp. You can do it either ways. You can pull the cartridge on the left or you can pull the this forceps on the right side, but avoid putting any undue force. Now this is the injector delivery system which comes with most of these lenses. You need to put in a drop of viscoelastic here because you don't want the air bubble to come in because then that air bubble would act like you might put in undue force while pushing in. So be very gentle, push in, express all the viscoelastic. Now this is very important. One very important critical point is the sizing of the main incision. So I always make it for the ICL is 3 millimeters. You don't want the incision to be too big because the moment it's too big, the whole visco comes out, the chamber shallows, and there are chances once you deliver, you hit the anterior lens surface. And if the lens is, the incision is too tight, then you try to do it on the incision, and then at times, either the lens comes out undelivered, or you try to forcefully push it, where you end up going on the reverse side. So it's always a temporo-clear corneal and 3 millimeter. I always mark with calipers 3 millimeters. I make 2 side ports and 1 main port, which is 3 millimeters. So this is the side port, 2 side ports. What I'm trying to show is avoid undue pressure like this. I have marked 3 millimeters, a scratch, and this is a 3 millimeter incision. And now there has been a debate between the viscoelastic to be used. So either HPMC or Helon, but whatever you use, we prefer using HPMC. The chamber should never be overfilled. The eye should never be overdistended because then it would lead to retained viscoelastic within the anterior chamber. So phenocaine or any intraocular lignocaine goes in, and this has tropicamide with phenylephrine, maintains dilatation, a gentle fill of the anterior chamber. And while inserting, you have to be very gentle. Don't use undue pressure. You have to use a guarded, gentle tap. Avoid lens touch. So in a routine cataract surgery, whenever you're injecting an IOL, you're directing it onto the posterior pole. Here, you're directing it to the opposite angle. So be very careful that it doesn't go up, hitting the endothelium, doesn't go down, hitting onto the anterior lens surface. So you have to be very gentle while inserting. A good tip that I would like to explain, and you would never have a flip. So you have, with the star, you have, in the toric, you have those markings linearly, and in this, you have the holes. You have a hole here, you have a central hole, and you have a hole here in the trailing part. So beautifully, what you have to do is, you have to observe underneath the microscope, go very slowly, and just see that all these three holes are in line. They have to be all in a single plane. You will never, ever have a flip of the lens and the lens going reverse. So watch carefully now. So this is the hole here, this is the hole here, and there is a hole here. So I'm just observing, going very slowly, and this would open up right the way you want. Never try to open the lens underneath the iris. A lot of people, what they do is, they want this to open underneath the iris. No, it should always land above the iris. So never try to push this underneath the iris while you are trying to inject the lens, because this could damage the anterior lens capsule. So very gently, you see the three holes, and this is what goes in. Just watch. At times you can manipulate, you can simply pronate your hand. If you see, now I feel the lens is going onto the right side. What I'm trying to do is, the injector, I'm trying to pronate my hand, and I'm trying to manipulate so that the lens goes in the right direction. Just watch carefully, and be very gentle. Be very, very gentle so that you can see how it's unfolding. Just watch the holes in the center. All the three holes are aligned, and it would never flip the reverse way. Just watch. All the three holes aligned, and it's gone in the right direction. Now push in viscoelastic over the lens so that you have a sufficient barrier between the endothelium and the lens, and then with the manipulator, you can tug in the lens. Now the plates, very gently, you can tug in using from the side port. The trailing, you can either go from the main port, or you can use again the side port, very gently. So for the marking, I know everybody has an access to this beautiful Mendy's marker, works very well. If you have those digital, you can again use this. You have this Verion or whatever automated system that you people have. Visco wash is a must, because you have to thoroughly wash the viscoelastic to avoid two main things: secondary rise in intraocular pressure, and at times it could give you a false high vault. And yes, pilocarpine at times, can cause entrapment of the viscoelastic, as Kamal rightly pointed out. Now, this is a quick word about how do you see post-operative. I would take my patient day one. The first thing is I do a slit lamp, check the anterior chambers, check the intraocular pressures, take the patient on an OCT, check for the vault, and sometimes for the toric, I would always do an eye tracy. If you don't have an access to eye tracy, a simple refraction is what is required. But yes, day one, then day 7, and 1 month. So these are the 3 follow-ups that we routinely do. Check for steroid responsiveness. So this is the OCT, we are checking the vault, and intraocular pressures, and so I've already talked about the troubleshooting, how you can address all these post-operatively if you have an unfair outcome. And if at all intraoperatively you feel explantation is very, very easy. You need not to increase the incision, just push in viscoelastic. With the manipulator, you can just gently trailing the foot plates can be expressed out within the anterior chamber, and with the same forceps where you grasp, it can be just held and just pulled, and it can be nudged out. So Thank you. Any questions on intraoperative? I would be glad to answer them. Yeah. Can you come on the mic? I think that will help all the audience also.
So two things. One, there are times when there are pupils which are not dilating well, and you have to implant because there's no other option for that patient. So any surgical tips that you can share that, because it is difficult. So do you go a size lower maybe, or in the white to white, or?
So actually, the sizing doesn't affect. I mean, the pupillary size.
At least it's easy to insinuate it under the
But then
iris.
you'll have a low wall. What
True,
why are you
true.
putting?
So how
No,
do
so
you deal
that's
with
a
that?
strict no for the surgery then. That's he has already pointed out. So if you
You
have,
would not operate.
yeah, so don't take these patients. If you have a very small pupil or for
No,
any
not
other reason.
very small, but it's you need a good dilatation.
So there are three things. So preoperative dilatation, USS. Intraoperatively, you use intraoperative phenocaine is a wonderful dilator. And then you can, in these situations, over-distend. So you can push in the viscoelastic. So the moment you over-distend, it tends to, the pupil tends to dilate.
Dr. Sanjay?
And then you have to be very carefully nudge these lenses. I mean, still you can manage these lenses. Now the difficulty happens in once you explant. So you are, trying to irritate the iris, so it constricts. And then you want to push in the ICL, then it becomes difficult. So in those cases, rather than taking the patient on the very same day, you can postpone. And then maybe after 2 days, talk to your patient, explain to him that we'll do the explantation. It's not 100% that we'll be putting the lens on the same day. Maybe we'll check on the microscope, and then according to your condition, we might do it after 48 hours. Because at times, whenever you try to explant, suddenly the pupil shut down. And then it is resistant to dilatation. So these are those tricky situations. But otherwise, preoperatively analysis for the pupil is a must. But most of these patients, usually dilate and they fare well.
Another one, sometimes at the end of implantation, just the tip of the haptic sometimes tears. It's a very small piece of the haptic because it's got stuck in the plunger and you've not been able to get it out well. And as you know, STAR doesn't give us a backup lens. So at that point, would you explant it, or if that small tear is it going to be okay to
See,
just
now
be
that's
there?
your call, because if you
But do
talk.
you know that it affects the vault?
Yeah, so it won't affect the vault, but it depends upon
cause
what the
cataract.
tear you are talking about. How much is the plate, torn? So if it's just a crack, if it's just a lena tear where the whole the anatomy remains normal, you can still go inside. But if you feel that you have broken and the piece has been separated, so the edge could rub against the anterior lens capsule, and in that case it can cause a cataract.
But
So
it would
better.
be in the periphery, no, sir?
No,
But then-
it can damage your zonules. A sharp edge can damage your zonules
Okay.
and then cause a localized peripheral cataract. So if you can live with that, fine.
Okay. So you would explant it?
Yeah.
Okay. Thank you so much, sir.
Thank you.
If it's a broken piece, explant it.
Sir, in the low vault cases, if there is a development of the anterior capsular opacities, for how much time you have to wait?
Why
Or you have
wait?
to immediately explant the lens, or wait to increase it and then do the cataract surgery?
So as I described in my troubleshooting slide, so with the V4C, with the central hole, it is said that the aqueous flow physiology is still maintained. So what we advise is dilate the patient, take a picture, look for the opacity, and then serially watch these patients, maybe once in 3 months. If every 3-month follow-up you feel that the opacity remains the same despite a low vault, with the V4C model, you can still observe the patient. But if you feel on serial photography or serial slit lamp examination, you feel that the opacity is increasing, now that's an indication for explant and maybe pushing in one size higher.
Okay, thank you, sir.
So I'll welcome, because of the paucity, we'll take one more question.
At the end of the procedure, even in spite of removing viscoelastic, we feel that the anterior chamber shallows too much after the procedure. In such cases, do you advise giving mannitol or something pre-operative patient?
Pre-operatively.
After completing the procedure, you have removed viscoelastic. When you remove your speculum, you see that the anterior chamber is very shallow.
So at times, intraoperatively, you will feel that the chambers are shallow, even despite, sealing the wound, you feel that the AC has not gone down.
Yes.
So it's not an indication for mannitol, because post-operatively, after 6 hours, once you see these patients, they fare well. I mean, the chambers are still open. So unless and until there is a rise in the intraocular pressure post-operatively, and the chambers are shallow, now that is then you have to estimate the vault. So you might have oversized the ICL. But otherwise, intraoperatively, most of the times you might feel, despite viscoelastic wash, that the chambers are shallow. But that is not an indication for giving a mannitol or any post-operative.
Not post-operative. Can we have a routine that we can give mannitol in such, in all
Intraoperatively.
ICL? Yeah, pre-operative.
Doesn't make any sense.
Pre-operatively.
No, we don't practice that. We, rather than don't give any blocks or don't give any intraoperative mannitols, don't use that.
Just one small little point. Sometimes you may have a very high IOP spike in a few cases within first few hours, especially if the viscoelastic has been there. So as a standard practice, in my practice, the patient stays for 2 hours before he leaves the hospital. Before he leaves the hospital, he's seen by any of the doctors. Suppose I have operated, I'm still in the operation theater on slit lamp. Digitally it's seen. If the cornea is slight steamy, digitally pressure is high. We just use the wound burping technique since you have 2 side ports. So any eye you work on, there is going to be a lower side port. Ask the patient to look upwards, 1 drop of proparacaine, 26 gauge needle, just press the side port, let 1 or 2 drops come out. Immediately within a minute, the cornea clears, the patient is fit to go back home. This may not be a very regular feature, but you'll be amazed. Maybe 2 to 3% of patients may have that, and you might get a call in the night, then I have some headache or something. So just avoid that. Let the patient stay for an hour or 2 hours, just burp the wound, send them back home. Next day, they come 6 by 6. Otherwise, next day, they come with headache and steamy cornea and all that stuff. So next speaker, Dr. Sonu, he's here, Dr. Sanjay Chaudhary.
So I would like to thank Dr. Sanjay Chaudhary for making us for this course. A very high volume, prolific surgeon. I think one of the India's most experienced ICL surgeons. So thank you, Dr. Sanjay, for making us. And I think we'll benefit from your talk, your experience with the ICL. And I'll request you to please cover your experience with the post-operative, any complications, the cataract, and what the low vault can have.
Thank you, Dr. Sonu, for inviting me over and for those kind words. So, okay, so I was given this topic of long-term outcomes after ICL surgery. So now I've been doing ICLs for about 19 years, a fair amount of experience that has gone with these ICLs, right from the time when the model was V4 without a hole to the present time when the model is V4C with the hole. And I've had experiences all through my journey, some of which I'll share with you. So, the biggest fear which most of the ICL surgeons have, the first thing they have on their mind is cataract. Sir, what are the chances of cataract? Because you're dealing with a young patient, a healthy cornea, a healthy crystalline lens, and you don't want a thing like cataract to happen. So, cataract could happen because of 2 reasons. One is the ICL crystalline touch, and 2, because of excessive irrigation in the anterior chamber, and probably the fluid jet hitting the anterior capsule. So, I would talk about the first, the ICL crystalline lens touch. In this, my talk would be in 2 categories. One, where there was a hole, and one where there was not a hole. So this is the vault, just showing you the vault of an ICL as related to the crystalline lens, and this is about 500 microns, plus minus 250 microns. So that means 250 to 750 is the perfect range. This guy, a high myope, this was the lens without the central hole. He was operated about 16 years back. And there was this, you can see that typically an ICL crystalline lens touch here. This was the pupil dilated, and you can see the entire form of the ICL. Can you see that? And you can see there is a whole line up this area where there is an ICL crystalline lens touch. And we could see that, but those were the early years, just 2 years into putting ICLs. We didn't know what to do. We talked to some of the colleagues who had some experience, some to our international friends at conferences. Sir, what should I do? Should I remove it and replace it with the higher size lens? Because the vision was just perfect. And the patient was very comfortable. He didn't want anything. He's got his perfect vision and is very happy. He's not complaining. Now, what do I tell him? That your ICL is touching and I need to change it with another ICL. Somehow, we came to the conclusion, okay, let it be, let it go. So we let it go, but we followed him up every year. And it was in the 5th year. It was in the 5th year that he developed what is this small anterior subcapsular opacity here. You can see it on the slit lamp here. Now again, we are still into the era where the central hole had just about come in. And we were wondering, now what should we do? Should we take it out and put it with a central hole with a higher vault? Or should we let it be? Ab cataract to ho hi gaya. Periphery pe hai, central vision, and the patient is still very comfortable. Again, the same dilemma. Should we not? Replace it? Should we not? Somehow we decided, okay, let it go. Let it go and let us see what happens. How much time does it take? Now that he's got a cataract, probably the opinion was that once the cataract has started, it's probably going to progress in any case. So we waited, and in 10 years' time, he developed sufficient cataract. He came back to us, and we said, okay, now we need to change your lens. So it was on the 10th year that we finally operated on him. I'm missing those slides somewhere. I don't know where those slides went. Anyway, so this was another case, again with the V4 model without the hole. You can see this retroillumination cataract, anterior subcapsular. You can see the slit lamp illumination. You can see the diffuse illumination. So these are just small specks, anterior subcapsular. Ever since the V4C model came in, and we have done almost 5,000 of these with the central hole, and not one cataract. Not one cataract, very surprising. So still we say there could be one odd case somewhere who's complaining of a cataract, but this experience has been shared by all phakic IOL users who are using these lenses with the central hole. Right, Kamal? So that fear that this phakic IOL, IPCL, ICL, biotech, whichever, the cataract incidence is almost negligible.
Until and unless the surgeon causes the cataract by touching the capsule while during the surgery. Yeah. That's an exception. Otherwise, you don't see it now.
Okay. Now, so even with low vaults, see this patient with a vault of 84. This is the minimum natural vault with an ICL. Even if the ICL is totally flat on the crystalline lens, it will have a natural vault of 80 microns. And even with low vaults follow up for 10 years, no cataract. This is almost touching at the periphery, just a central vault there. But because the fluid is moving, there is no aqueous stasis through the hole, the cataract, it seems, doesn't develop. The proper nutrition is going to the anterior capsule, so that activity does not set in. So, lots of people who are the net savvy people, they have somewhere read about cataracts with ICL, and they have this first question in their mind: sir, what about cataract? Will we have a cataract? Everybody is already aware of the phakic IOLs. They have read everything about it. They have seen all the complications happening. So This is what we tell them. But however, we do not say that the incidence is 0. We say the incidence is negligible, 0.1%, because saying 0 may not be the right word, because somewhere may have reported a cataract. I tell them it is safer than going out on the road. So the road risk is more, but you still come here. So the idea is that if your advantage is huge and your risk is minimal, then that risk is worth taking, like you come out on the road. The same thing is with an ICL. The risk is even less than what you would have when you go out on a road. That's a very convincing line for people. So in rare situations, things can happen, but well, rare things are very rare, but in any case, you don't get to lose any vision. So that is again very, very encouraging. Okay, now this is a very important topic which I want to discuss with you. The excessive irrigation or fluid jet hitting the anterior capsule. Now, this is not a long-term effect. This may be a short-term effect. Now, look at these images. On the left, if you look at this image, the first thing you would get in your mind is visco on the crystalline lens. Even when we saw this slide for the first time, one of the speakers said, okay, tell me what is this? Visco on the crystalline lens. Yes. So that will go away. So this is retroillumination. This is the diffuse illumination. And at 3 months, this was almost gone. You can just see one odd specks here. Right. So it probably seemed visco on the crystalline lens, which just dissolved away. But then if it was visco on the crystalline lens, what if we start doing surgery without the visco? Which I then started. Not exactly because of this, but just it was faster and I was not using the visco. So my early post-op rise of IOP became 0. What we were just talking about right now. Early post-op rise because of visco, 0. No headaches, no pain, cornea crystal clear, vision is almost good in 2 hours. So I got another strong proponent of visco insertion. We all started with visco hydro insertion of ICL. And to my surprise, one day, after 2-3 years, I again had a similar position. You see this? And again on a slit lamp, you see this kind of an image. I said, now where is this coming from? I'm not using visco. Then maybe I thought that it could be because in the injector you use a little bit of visco, but the amount that is showing here is not even the amount that I push in through the injector and I just suck it up immediately. That little bit of traces. Well, where is this getting from? But then this also started resolving over a period of time. This is the 30th day post-op. So we thought, okay, something is happening. But then for years, nothing happened till one day again we had a jolt like this. In the previous versions, at that time, I didn't have an ASOCT, but now we had an ASOCT to see exactly what is happening. And we also looked up the literature. And the literature said that now first reported, this is just a few years back, anterior subcapsular vacuolar changes of the crystalline lens in patients after phakic IOL. So anterior subcapsular vacuolar changes, which kind of mimic an anterior subcapsular cataract. So this same patient, which I showed you here, this patient, after 6 months, the peripheral area is almost clearing up. It's all collecting in the center. And look at this, what is happening. At this time, we have our OCTs, ASOCTs working very well. You see this anterior subcapsular changing. It's all collecting. From the periphery, it's collecting towards the center. And in the center, it's showing this vacuolar change and a deposition of this lenticular matter under the anterior capsule. So the take-home message from this part was that visco has no role in inducing subcapsular vacuolar changes and cataract. So do not fear a visco. Visco may be okay that you have an immediate post-op rise of IOP, but it is not responsible for cataract. It actually does not stick to the anterior capsule much. Excessive irrigation. That is the culprit. And when you're putting in jets under the ICL, you're taking that jet under the ICL and trying to irrigate out that visco because you're afraid that is the visco that is going to get stuck into the trabecular meshwork and cause an early IOP rise, and patient will be screaming in the OPD and saying, what have you done to my eyes and whatever. So that puts the surgeon on the back foot. He tends to irrigate more, and that is where the problems start. So I have totally converted to hydro insertions. And that visco is so minimalistic, it really doesn't make a difference. And I work on low IOP settings, low bottle heights, minimum irrigation flow and irrigation time, and do not irrigate in the narrow space between the ICL and the crystalline lens. That is the rule. Put it in your mind and you will be very safe. The second problem, glaucoma post-op. Again, a fear for most of the surgeons. Short-term, long-term. Short-term, we have already discussed as a part of what we had an informal discussion, that the visco clogs up the trabecular meshwork and there's an IOP rise, and you know how to manage that. Nothing special about it. I'm talking about a high vault, a very high vault. So see on the left, it's a very high vault. The AC is very shallow. You can see the contour of the cornea and the contour of the iris. And you can make out that this is a very high vault. And this is a pentacam. Why we did the pentacam was because the pentacam gives us a picture of the cornea with the iris and the crystalline lens all in one. The AIOC, the ones which we have right now, may not take the whole picture in one go, but it gives you a better resolution. So you see in the pentacam picture, the kind of profile of the iris, but still there's a clear space continuing from the center to the trabecular meshwork. And this vault was 1,456, over 1,400, which is not only high, it is very high. The question was, should we remove it? The pressure is normal, the vision is normal, everything is fine. We have done the specular, we are keeping a track on the specular counts. We let it be. And the patient is still doing fine after 3 years. And what is interesting is this situation. Another situation of a vault which was 1,583, 1,600 vault, 1,600. You would say, you are crazy of not taking it out and placing it by a size lower. Again, the whole space between the iris and the cornea is clear, so the access to the trabecular meshwork is okay. This was day 1. At 1 month, the vault decreased. From 1,600, it came to approximately 1,500. A decrease in 100 microns. Why? I really cannot explain that. Maybe some of the faculty here can help me. At 8 months, it decreased by another 100 microns, 1,300. At 14 months, another 100 microns. It's just going down. So the inference could be that if your vault is high, maybe just watch, wait and watch, things could get better. Now, this is a very high vault. This is touching the endothelium. Something has to be done about it. You can't let this pass. So, this is the same patient, such a high vault. There was ectropion of the uveal tissue because the iris was rubbing strongly against the ICL. Very high vault. We had to take it out. So here we plan to take it out and see there's hardly any space in the AC. Even the instrument can't comfortably go into the AC. Remember, such a situation, it will be very difficult to reach out to the lens and pull it out because there's no space. Okay, just a minute. Yeah, okay, just a minute. So I'll just show you how you could comfortably still remove such a lens and replace it with one size lower. And what was the result? You see that the instrument It's just almost difficult to put the instrument into the eye. Then you have to try to push the lens down as much as possible with the visco. Be very sure that there's a strong chance of the iris coming out with the visco. So you have to be careful that there is no reflux back of the visco and bringing the iris along with it, though that will constrict the pupil and cause a lot of iritis. And now the manipulation starts. How do I get a grip on a lens which is so tightly into the sulcus, and how do I get the edge of this lens? So I cannot prolapse this lens into the anterior chamber. I just pull it back and try to get the grip at the edge, and then just pull it out of the AC. So this is what was to be shown, and then you can replace it with one size lower. And this is how the patient looked after you put a one size lower. The walls had recovered so well. Thank you so much. But the last one, in a case of a patient operated somewhere, came to us 4 years post-op, and the lens was upside down. So the lens was resting on the optics were resting on the crystalline lens, and the haptics were pushing the iris against the cornea for 4 years, and he was on anti-glaucoma medications. So, of course, we had to remove this lens and refer the patient to a glaucoma specialist to manage the rest. Thank you so much.
Wonderful video, Dr. Sanjay. I think you shouldn't get scared seeing such videos. We don't see these complications very often, but yes, when they do happen, they can be nightmares. So over to Dr. Gaurav. We've saved the best one for the last. No need to introduce my friend Gaurav.
Yeah, please.
Yeah, sure.
Can you be a little, can't hear you. Yeah. Yeah.
If such situation arise that we have to take the lens out, is there any special forceps for that, and where it is available?
What I use is, you could use your ICL forceps, the one which you are using for pulling the ICL into the nozzle, right? After having said that, because that is the most easily available, but what I use is a lens holding forceps which you use to cut an IOL in the eye and bring it out. They have a very fine grip. The one comes with Indo-German is such a lovely grip. It's the one which you saw now. So that just holds and brings it out very comfortably.
Worked in every other hall except
I would suggest, in case you have these forceps, they work great. You can have another trick. You just push in viscoelastic in the anterior chamber. The leading loops of the ICL oblique IPCL, which are towards your wound, just get that out. The trailing one can remain behind the iris. Now slightly dip your wound, the viscoelastic will start flowing, and it will start pulling the lens, because the lens is very thin. It starts coming towards the wound and the lens stops there. Now all you need to do is, now use more viscoelastic from the side port, go in, use a McPherson's forceps. Hold it, pull it out, and as it starts coming out, you just use a needle holder or your needle bending forceps, whatever you use, just grasp it, and like a tug of rope, just pull it out, it comes out. So in case you have those fancy forceps, fine, but in case you don't, that's what I do in my training programs. I have my associates, whenever I train a person to do a phakic lens, I also train them to explant it, otherwise the training is not over. I always tell them that remember what happened to Abhimanyu. He knew how to get inside the Chakravyu, he never knew how to come out. So if you are going to be a phakic IOL surgeon, you should know how to get out also. So the best way to train is train your trainees in patients who have cataracts. So that's how I train my doctors. Anybody who's got a cataract, I get blanks lenses, zero-powered lenses. I have hundreds of them. I just train them, put the lens in, take it out. In a cataractous patient, it doesn't matter. Within 1 or 2 attempts, they are perfected and you're ready to go. Dr. Gaurav.
Secondly, sir, which point it should be held for the haptic, in the central part, optic portion of the haptic?
See, in any case, that lens has to be sent back. Now, the only question is, do you first remove the lens, wait, order, and then put in the second lens? Or do you do the two things simultaneously? You order the second lens, and when it comes in one sitting, you take out the first lens and put the second lens, right? That depends on the situation, the severity of the situation. If the severity is like the video I showed you, I couldn't wait for 2 weeks or something to get another lens. That would have caused problems. The moment I saw this kind of a situation, I immediately pulled it out and ordered for the second lens. I told the patient.
Suppose it is reverse. It has gone reverse. I mean, upside down, downside.
If it's upside down,
yeah, then we have to take it out and then immediately.
Immediately, because then you'll have such bad adhesions 360 degrees.
So which portion it should be hold? Either the optic
In 360 degrees, it is very simple. The haptics are pointing upwards.
Right.
The moment you expose any part of the haptic, just hold it and pull it out.
Okay, thank you.
Gaurav, are you ready?
Sanjay sir, in one of your
Acha.
case,
Can somebody help from the AV team?
Yeah,
Yeah, please go ahead.
the vault was 1600, I think, 1800 to 1600.
1600, yeah, that was the maximum.
Down in 8 months to 1200.
Yeah.
How it was possible?
I still don't know. I said I really cannot explain that myself. We were just observing that patient and asking him for a follow-up every 3 months. Right? And then it was to our surprise that the vault went down. I said that it was to my surprise that the vault kept going down, and I was wondering how is it going down? How do you explain it? It's an ASOCT.
I'll try to show something.
We'll take the question afterwards because we are running short of time. So let's hear from Dr. Gaurav Luthra. He is again a very high volume phaco-refractive surgeon and a high volume ICL surgeon from Drishti Eye Center, Dehradun. All to you, Gaurav.
Thanks, Sonu. Actually, it's not running from my laptop. They're doing it from there, so I'll just try to do whatever I can.
Can you help, please? Can you just coordinate? Yeah.
So I'll see if the video plays. I don't know. I think there's no point doing it. I'll just call it off here.
Started.
Anyway, this is some video. I can't see it here, so I'll have to just look there and tell you. This patient was, okay. In fact, let me just see if I can. I think Grover has gone crazy this time. So this patient was an ICL patient. We've done a 3 mm incision for injection. This wound sometimes will not seal perfectly and it will be a leaky wound. You can't suture them because you've done a toric ICL. So if you have a ICL situation where you have a leaky wound, instead of suturing it, you can just make this supraincisional small pocket and hydrate it, and then you can actually get a very good seal on that, so you don't have to suture them. Now this is another patient. This sometimes happens with IPCLs. I don't know if I can play this video. Let's see. Okay. So this happens with IPCL sometimes. You put in an IPCL very nicely and goes very easily. Actually, the injection is very much easier than even with the star ICL. So it's much easier for surgeons who are used to doing phacos and IL injections. So once it is positioned nicely, you can you think that the job is over, but sometimes the job is not over there, and you can see that the haptics go in very easily. So it's not a oversized or any other kind of a situation here. Now, once you've done it, you should wait to see that the pupil, even though we don't use pilocarpine nowadays anymore for all our surgeries, yet you must wait to see. I sometimes increase the illumination of the microscope, and I wait to see that the pupil covers the edge of the optic. And you can see here that it's almost there, but I notice that sometimes if you have a slightly higher vault, the iris will start going behind the optic of the lens. Now, if that starts happening, you can't leave it like that because it will just keep a self-perpetuating kind of a situation. So it's always great to observe till the end. And now I've put a little bit of pilocarpine and made sure that one of the sides is covered now. And then I'm waiting for the other one, but it is not. And usually these vaults will settle down post-op, but these patients must be kept on watch. Sometimes later on when you dilate them, they will still have a optic which is caught on the pupil. So this can happen with IPCL sometimes and does not happen so much with the star ICL as I've seen except one patient. So going on, I think I'll just go on to something more interesting. Let's see, because there's almost little time left. But sometimes you'll have a first eye where you get a low vault ICL, and then you can always change it for the second eye to the higher vault ICL. But what do you do for the first one? Now, if it's just like a vault which is not too low, you can still carry on because with the central flow now nothing much happens. So if it's like 100, 150 microns vault, but if it's like a 50 microns, then you'll have to do an ICL exchange. So somebody was asking what kind of forceps you will use. So best thing is to just use the ICL holding forceps itself, which is best suited for this. You can hold the ICL from one of two places. Either you can hold it from one of the haptics, or you can hold it between the two haptics as you would hold it while loading the lens. Nowadays, I like to hold it just from one haptic and pull and a 3 mm incision. It just kind of twists and comes out. So this is a very old video, so you'll see my old forceps. This was almost 10, 15 years back, I think. So the ICL, and here probably I'm holding it from between the two haptics. So nowadays there are better forceps available, and even the MST IOL holding forceps is very good. So ICL comes out very easily and can be re-injected. Let's see if I have any other thing. Yeah. Sometimes, end of the OT list, you have an ICL posted, the pupil constricts, and that time you have a situation, so you don't have to abandon the surgery. You can just put phenocaine and it works quite well. So this patient came into my OT towards the end of the OT for an ICL. I think she's, yeah. I think we'll stop here because you can just put phenocaine and complete the surgery over there. So I think we ran out of time. You can just inject phenocaine. You can see how fast the pupil is expanding, and within about 10-15 seconds, you can proceed with the surgery. So I think everybody has already covered most of the things that were required, so I'll just stop here. Thank you.
That was fast, Gaurav, as fast as your brain.
In the time given by you, 2 minutes.
Thank you, Gaurav, and thank you for being a part of the course.